Hello, welcome to my channel. So today we are going to talk about pneumonia. So pneumonia is an interesting topic, but this is more of an internal medicine pneumonia. So usually in elderly, not in the pediatric pneumonia. Okay, so objectives, we're going to cover definitions, we're going to cover risk factors, we're going to cover classification, we're going to cover etiology, we're also going to cover brief pathophysiology, stages of pneumonia pathology, we're going to cover clinical presentations, we're going to cover investigations, treatment, and differential diagnosis, complications, as well as the prognosis and prevention. So in terms of definitions, pneumonia is the inflammation of the lung parenchyma, that is the alveoli rather than the bronchi. Then risk factors for pneumonia can have cigarette smoking, upper respiratory tract infections, so any recent influenza infections. There are some of the other risk factors. Then the other risk factor is alcohol, aspiration of nasopharyngeal or gastric secretions, and have bacteremia and abdominal sepsis. Then you can also have corticosteroid therapy for a long period of time. You can have old age, then pre-existing lung disease, so it's supposed to be lung disease. So pre-existing lung disease can have reduced host defenses against bacteria when there is reduced immune defenses. Then if you have a reduced cough reflex, e.g. post-operative, if you have an infected emboli, okay, those are some of the risk factors. Okay, then in terms of classification of pneumonia can be classified in number one, we have anatomical classification, where we have lobar pneumonia, which affects only a lobe or section of a lung. You can have lobular pneumonia. You can also have interstitial pneumonia, which is common in atypical pneumonia, and it involves the areas in between the alveoli. Okay, and then you can also have a bronchopneumonia, which affects the lungs in patches around the bronchi. Then you can have clinical classifications also. So that's our number one classification. Then second classification is clinical classification. So under clinical classification, we can have community acquired pneumonia. And then community acquired pneumonia examples, we can have a typical pneumonia, atypical pneumonia, and aspiration pneumonia. Then under the same clinical classification, we can have nosocomial, where we have hospital acquired pneumonia, where we have ventilator associated pneumonia, where we also have healthcare associated pneumonia. Then the last classification which we can have is pneumonia in immunocompromised hosts. Okay, then moving on to now, we go in details with the classifications. So we talked of community acquired pneumonia. Also, we have an infection of the pulmonary parenchyma associated with symptoms of acute chest infection, and the presence of the same acute chest, there will be a presence of acute chest infiltrates on the chest X-ray, or scaltating findings will be consistent with pneumonia in a patient not hospitalized or residing in healthcare facility for more than 14 days prior. Then occurs across all ages. However, it is commoner at the extremes of age. Okay, and then that's all about community acquired pneumonia. The next is, we can have hospital acquired pneumonia, which is defined as pneumonia that occurs 48 hours or more after admission, which was not incubating at the time of admission. Then we can also define it as new onset of cough with purulent sputum, along with a compatible X-ray demonstrating consolidation in patients who are beyond 2 days of their initial admission to hospital, or who have been in a health care setting within the last 3 months. Then the causative agent is different from those of community acquired pneumonia. So examples can have the things which most likely cause the hospital acquired pneumonia, but viral or fungal pathogens are not responsible in immunocompetent hosts. That's what you have to know. And then we can have aerobic gram-negative bacilli, which is commonly involved. So, for example, we can have a P. aeruginosa species, we can have E. coli, we can have Klebsiella pneumoniae, we can have Acinetobacter species as well. Okay, then Staphylococcus aureus is increasing in hospital-acquired pneumonia, especially the MRSA. Okay, then the hospital-acquired pneumonia, so that's the app, hospital-acquired pneumonia due to Staphylococcus aureus is more common in patients with diabetic mellitus, head trauma, and patients on ICU. Okay, and then the other pneumonia which we are going to talk about is ventilator-associated pneumonia, which refers to pneumonia that arises more than 48 to 72 hours. So supposed to be 22 hours. So 72 hours after. So after endotracheal intubation. So the endotracheal intubation is just one of the common sources of ventilator-associated pneumonia. So the other examples, it can also be due to aspiration, due to the same intubation procedure, can due to biofilm formation, it can be due to contaminated secretions, it can be due to contaminated respiratory equipment, as shown in the picture. So these are the common sources of ventilator-associated pneumonia pathogens. Okay. Then we can have healthcare-associated pneumonia, where we include patients who was hospitalized in an acute care hospital for 2 or more days within the 90 days of infection. We can have those who resided in a nursing home or long-term care facility, or those who received recent IV antibiotic therapy, chemotherapy, or wound care within the past 30 days of the current infection. That's healthcare-associated pneumonia. Or those who attended the hospital or hemodialysis clinic. Okay. Then the other thing we have to talk about is atypical pneumonia. So clinically, atypical pneumonia presents with a subacute onset, fever which is less common or intense, and have a minimal sputum. Then microbiologically, we can have a sputum that does not reveal a predominant microbial etiology on routine smears. So in terms of gram stains and zeolnis and stains, then or cultures as well. So that I don't reveal a predominant microbial etiology. Then geologically, there will be patch infiltrates or interstitial patterns. Then in terms of causes of atypical pneumonia, the mnemonic you can use to remember the causes is LP MCQs, so lumbar puncture MCQs. That's just to help you. L is for regions, so for Legionella pneumophila. The P is for pistache, which is Chlamydophila, which is Chlamydia pistache. Then M is for Mycoplasma pneumoniae. Then C is for Chlamydophila pneumoniae. Then Q is for Q fever, but specifically it is Coxiella bonnet. Those are some of the causes of atypical pneumonia. Okay, then you can also talk about aspiration pneumonia, which occurs in overt episode of aspiration or bronchial obstruction by a foreign body. So there will be acute aspiration of gastric contents into the lungs. Or it is also seen. It is also seen in alcoholism, nocturnal esophageal reflux, a prolonged tension in the dental chair, also in epilepsy as well. Then it is usually caused by anaerobic agents. Then we can also talk about pneumonia in immunocompromised hosts. The immunocompromised patients are at risk of pneumonia from the usual organisms as well as the opportunistic pathogens which would not be expected to cause the same disease. So these opportunistic pathogens can be commonly occurring microorganisms or bacteria, viruses, and fungi that are less often to cause pneumonia in immunocompetent hosts. That's the thing about pneumonia in immunocompromised. Okay, so that's the end of us going through the classifications Then in terms of causes, so usually we talk about the infectious causes. So infectious causes, we can classify them as bacterial, fungal, parasitic, and viral. Then under bacterial, we can have Streptococcus, pneumoniae, Legionella, Haemophilus, Chlamydophila, pneumoniae, Staphylococcus aureus, Moraxella, Catarrhalis, Streptococcus pyogenes, Neisseria meningitidis, Klebsiella pneumoniae, Haemophilus influenza. So these are some of the bacteria causes. Then viral causes, we can have influenza virus, adenovirus, rhinovirus, and also respiratory syncytial virus, RSV. Then under fungal, we can have Candida albicans. We can also have coccidioides, which causes coccidioidomycosis. We can also have Histoplasma, which causes histoplasmosis. We can also have Aspergillus, which causes aspergillosis. We can also have pneumocystic gyrovec, so which causes pneumocystic gyrovec pneumonia, which is PJP. Okay. Then under parasitic, so under parasitic, we can have so we have to know that parasitic pneumonia is rare, and it occurs almost exclusively in immunocompromised people. Then parasites involved include Ascaris lumbricoides, Cytosoma species, Toxoplasma gondii, Paragonismus, then also in Aerostrogus species. These are some of the parasitic causes. Then that's the end of infectious causes. Then in terms of pathophysiology of pneumonia in relation to the infectious cause, so any infection to the lungs, so e.g. caused by bacteria, viruses, or any organism that causes an infection, there's going to be an inflammatory response that's going to be initiated, then which will lead to alveolar edema plus exudate formation. Then when there is alveolar edema and exudate formation, so the alveolar edema is going to come about due to increased capillary permeability. So there will be alveolar edema due to extravasation of fluids. So then the alveolar edema is also going to the alveoli and respiratory bronchioles will fill with serous exudate, blood cells, and fibrin and bacteria, okay, due to increased extravasation. Then which will lead to consolidation of lung tissues, then which will impair even the alveolar gaseous exchange and will lead to the symptoms we are going to talk about. That's the brief pathophysiology. Then in terms of stages of pneumonia pathology, so stage number 1, we can have a congestion or edema. So under congestion or edema, we can have presence of a proteinaceous exudate and often of bacteria. That's if it is bacterial. Okay, then which is in the alveoli. Then the main bacteria are present, but few white blood cells are available to fight the infection. That is under congestion or edema. Okay, the next thing we can talk about is red hepatization. So red hepatization, this is where we have presence of erythrocytes in the cellular intraalveolar exudate. Neutrophils are also present. So that's why we call it red, because of the predominant erythrocytes. Then bacteria are also occasionally seen in cultures of alveolar specimens collected. Then stage 3, we can have gray hepatization, where we have no new erythrocytes or extravasating, and those already present have been lysed and degraded. The neutrophils are the predominant cells. Then fibrin dispositions is abundant. Okay, then bacteria have disappeared in the gray hepatization. Then it corresponds with successful containment of the infection and improvement in gaseous exchange. Then lastly, we can have resolution where we have the macrophage as the dominant cell type in the alveolar space. Then debris of neutrophils, bacteria, and fibrin has been cleared, and the normal lung tissue is usually restored, and the person's gas exchangeability returns to its normal function. That's the end of the stages of pneumonia pathology. Then in terms of clinical features, we can have general symptoms such as high-grade fever, productive cough, pruritic chest pain, and breathlessness. Then additional symptoms, we can have sharp or stabbing chest pain, headache, excessive sweating, and clamming skin, loss of appetite, and fatigue, confusion. That is especially in older people. Then general signs, we can have febrile, tachypnea, central cyanosis, hypotension, altered sensorium, use of accessory muscles of respiration, confusion. That is in advanced cases. Then signs of consolidation. So when someone is having consolidation on your examination, the signs you're going to see on his percussion is to have a dull sound. Then on your auscultation, there will be bronchial breath sounds. In the lungs, there might be crackles, which may be fine or coarse. Then there also could be increased vocal resonance, and the other auscultation findings can be pleural rub. Okay, so just depending on your finding. Then on palpation, there will be a diminished tactile vocal fremitus. And then if the patient is also in the investigations, the investigations we can do is so under investigations we can have laboratory we classify them laboratory and radiological. Then under laboratory, but here specifically we are going to classify them as laboratory, radiological, and intensive investigations. In the laboratory, you can have full blood count where we have the white cell count, which will be increased. So it will be increased, something increased. Okay, so the white blood cell count will be increased. So a range can even be given to 15,000 to 25,000 cells per cubic meters. Then the other findings is that the HB can be normal or slightly low. Then the culture and sensitivity of the sputum, throat swab, nasopharyngeal swab, pleural rub, and blood, or which is bacteremia, can be found in 10%. Then the last three, you can have urine culture and sensitivity as well. Then others can have blood sugars, electrolytes, and creatinine. Then the under radiological findings, we can have chest X-ray. You can do a chest X-ray. Then the chest X-ray findings, if it's viral, then there will be hyperinflation, perialar infiltration, aira adenopathy, and atelectasis. Then if it's bacterial, there may be alveolar consolidation. Then if it's a lobar pneumonia, there will be a peripheral airspace consolidation pneumonia without prominent involvement of the bronchial tree. Then if it's a bronchopneumonia, then there will be a centrilobular and bronchiolar opacity pneumonia, which tends to be multifocal, and they will be patch in distribution rather than localized to any lung region. That's a bronchopneumonia. Then interstitial pneumonia, there will be a peribronchiovascular infiltrate. Then on the chest X-ray findings, if it's a fungal cause, there will be reticulonodular infiltrates, and it's one of the common MCQ questions. They ask you someone, they present a scenario, then they say what will be the chest X-ray findings in this patient. So they are telling you that the patient has a fungal infection, has a fungal pneumonia, then what will be the chest X-ray finding. So remember, it's reticulonodular infiltrates. Then the other radiological investigations, we can have CT scan and USG of the chest. Then lastly, you can have invasive procedures. Then we investigate for the same. So invasive, we can have bronchoscopy, we can have thoracoscopy, we can have percutaneous aspiration or biopsy. Okay, then and also low open lung biopsy as well, and pleural aspiration for investigate for either MCS, or DNA expert, or this will just investigate the pleural expression that you have gotten. Then other tests can have a bacterial antigen in sputum and urine, rapid viral antigen detection as well. Then that's the end of our investigations. Then you can also talk about the CABE score, the CABE 65 score. So C is for confusion, which is present and abbreviated, and you can grade it with abbreviated mental test score of less than 8. Then urea, where we have the plasma urea more than 7 millimoles per liter. Then respiratory rates, there will be respiratory rate of more than 30. And then in terms of blood pressure, which is B, there will be hypotension. So the blood pressure will be, the systolic blood pressure will be less than 90 millimeters of mercury, diastolic less than 60 millimeters of mercury. Then 65 is for age more than 65. Then usually give 1 point for each of the above. So if you get a score of 0 to 1, you treat as an outpatient. If you get a score of 2, you admit to hospital and treat there. Then if you get a score of 3 plus, often require ICU care. Then you have to note that mortality increases with increasing score. Okay, then treatment, so the general treatment, the general management is that oxygen therapy, if the saturations are less than 94% of O2, the intravenous fluids, but don't overload patients with a lot of fluids. And then antibiotics should be administered within 4 hours of presentation in hospital, and treatment should not be delayed whilst investigations are waited. Then you can also use thromboprophylaxis unless contraindicated, physiotherapy if sputum retention is an issue, then nutritional supplementation as well, analgesics as well. Okay, then for a more specific management, if you're using the CABE score, so if you use the CABE score and you find that this is an outpatient, so outpatient treatment, or if it is an empirical treatment, so be it if you know and if you are just treating it as empirically. So if in a previously you use it in a previously healthy and no antibiotics in the past 3 months, or there are 2 criteria. You can give these antibiotics in previously healthy and no antibiotics in the past 3 months patients. You can use a macrolide, be it clarithromycin or azithromycin or doxycycline. Then for those who we are treating as outpatients and had comorbidities or antibiotics in the past 3 months, you can use respiratory fluoroquinolones such as moxifloxacin, levofloxacin, or beta-lactams, where we use high-dose amoxicillin or amoxicillin clavulanate. Okay, so that's amoxicillin with clavulanic acid. Okay. Then for inpatient or non-ICU patients, so meaning they're just within the hospital but not in ICU. Okay. Then respiratory, we can also use the same respiratory fluoroquinolones, moxifloxacin or levofloxacin. You can also use beta-lactams such as IV cefotaxime, IV ceftriaxone, IV ampicillin, or then plus a macrolide, or clarithromycin or azithromycin. Then for inpatients who are ICU patients, you can also use beta-lactams, the same IV ceftriaxone, IV cefotaxime, IV penicillins. Then you also add azithromycin or fluoroquinolones as well. Then differential diagnosis for pneumonia, we can have asthma, congestive cardiac failure, meningitis, acute abdomen, and also as well as tuberculosis. Then in terms of complications of pneumonia, we can have we classify complications as local complications and systemic. So under local, you can have empyema, which is a pus in the pleural space. You can have lung abscess, which is collection of pus in the lungs. You can have pleural effusion, which is abnormal fluid in the pleural space as a result of inflammation. You can have necrotizing pneumonia, which is necrosis or liquefaction of lung parenchyma. You can have pneumatocyst, which is a thin, odd, air-filled cyst of the lung, often occurs as empyema. Okay, then other respiratory complications, we can have respiratory failure and acute respiratory distress syndrome. Okay, Then complications of pneumonia. The other classification is systemic. So we have local and systemic complications. Then under systemic, we can have meningitis under CNS. Then under CVS, we can have endocarditis, pericarditis, and as well as shock. Then under GIT, we can have peritonitis, we can have acute abdomen. Then under the upper respiratory tract system, we can have otitis media. Then under hematologic, you can have septicemia. Then under the renal system, we can have renal failure. So that's some of the things you have to know about the complications. Then in terms of prognosis, this is in most healthy patients, they usually recover from pneumonia in 1 to 3 weeks, but pneumonia can be life-threatening as it can just bring the patient with respiratory distress syndrome. The patient is not able to, the patient is confused, they have hypotension, those keep score criteria. Then the mortality rate, with community acquired pneumonia is very low as well, especially in most ambulatory patients, but it is the mortality rate is higher in patients requiring hospitalization, and being as high as 35% in patients admitted to the intensive care, to the ICU itself. Okay, then that's the prognosis. Then prevention, we can have if patients smoke, tell them to stop smoking, better nutrition, good respiratory hygiene measures. Then if they are not vaccinated, we can also vaccinate them against the pneumococcal polysaccharide vaccine, which is Pneumovax, or a pneumococcal conjugate vaccine such as Prevnar for children less than 2 years. Then you can also give them inactivated influenza vaccine or a live attenuated influenza vaccine. Okay, so that's the end of the tutorial. Thank you for watching. If you haven't subscribed, please subscribe and hit the bell notification. And thank you for attention once again. See you in the next tutorial.